Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Today we have another special guest, Mike Atkins, joining from Georgetown University. Thank you, Mike, so much for joining us today.
It's my pleasure to be here. I love talking to you guys about melanoma and immunotherapy.
And maybe a little kidney. We might dip into a little kidney today. Mike,
that's fine with me as well.
We think it's always fun for our guests, for our audience, to hear from our guests, maybe just a little bit about their background, where they did training. Are you an East Coaster your whole life? Or a little bit like Jeff, when Jeff was on, he told us about his sort of ping-ponging back and forth around the country. Can you tell us about your background?
Sure. So I grew up in the Midwest in a town called Milwaukee, which is north of Chicago in Wisconsin, for those of you who aren't in the United States. And I came from a family of committed cheeseheads. Everybody else in my family went to the University of Wisconsin. And I went out east to Boston for college at Tufts University. And I stayed in Boston for 40 years. I went to Tufts University, Tufts Medical School, did my internship and residency and chief residency at Tufts New England Medical Center, did my fellowship in HEMONC at Tufts, and was on the faculty there for 10 years without moving, without ever having to interview for any job or anything like that. But then I moved across town to Beth Israel Deaconess and the Dana-Farber Harvard Cancer Center because of the opportunities presented there to work with really talented scientists across the Harvard system. At Beth Israel Deaconess, I led the kidney cancer program. I founded the kidney cancer program and the kidney cancer spore, and co-led the melanoma program, and was deputy director of the melanoma spore, the first melanoma spore ever funded, and also led the biologic therapy program, where we were heavy into high-dose interleukin-2 treatment for patients with melanoma and kidney cancer, probably the largest volume of any place in the world, even probably treating more patients than the NCI surgery branch at our heyday. And so we were very committed immunotherapists, but we knew that couldn't get above the 15% ceiling with high-dose IL-2. So we spent a lot of time trying to figure out how to make immunotherapy work better for patients. And we thought about combining it with chemotherapies, combining it with targeted therapies, combining it with anti-angiogenic therapies, we could get more responses, but we couldn't get more cures. And so we delighted when the checkpoint inhibitors came along, and we saw ability to treat not just more patients with melanoma and kidney cancer, but also potentially working in patients with other types of cancer. And then this was different. And I said, if I'm going to actually do this, I need to break away from the current mold and go to another institution to try to lead this effort and introduce this effort at another institution. So I moved to Georgetown 12 years ago, where I'm deputy director of the Cancer Center and have led our immunotherapy initiatives and have been able to stay involved with the immunotherapy space, particularly my colleagues in Boston and within the melanoma community, which is a very tight-knit community from decades of banging our head against the wall to actually be able to participate in this revolution in cancer therapy.
Yeah, so maybe if I could ask a first question. and I suppose it's about cytokines, because back in the day, that was really the only game in town, I suppose, for immunotherapy. So my question would be now, 2024 going into 2025, do you see any role currently for cytokine treatment? That's sort of part one. And then part two would be, what do you make of some of these sort of reformulated IL-2s that we've seen a bit of in the last few years? Do you think they may find a place or not?
Those are great questions, things I've spent a lot of time thinking about. I've not used high-dose IL-2 since I left Boston. So I'm not as close to that space as before, but I do think that IL-2 still has a role, particularly in cellular therapy. It's part of the TIL program. I don't think it's something that we would give commonly to patients with metastatic melanoma or kidney cancer. The therapeutic index just isn't there. But I think it was very instructive because it told us that we could cure some patients with solid tumors, that the immune system actually works, and it kept the field alive while we were trying to figure out how to break through the 15% response barrier. I think that we knew that from the work of Steve Rosenberg and TIL that there were T cells in the tumor that recognized the tumor, and that we could get them expanded with enough with IL-2, we might see a response. But we didn't know what was keeping them from being more active in the tumor microenvironment. If you took them out, they were able to recognize and kill the cancer, but living in the tumor microenvironment, they just didn't. And that's where the checkpoints discovery opened up that box. So getting back to our experience with high-dose IL-2 and how that informed these new engineered IL-2s, we saw early on, and I was just looking at this data for because I was talking to some people about the olden days, and we saw that when we gave high-dose IL-2, not only did we activate non-specific T cells throughout the body, which was responsible for the toxicity, but we also activated T regulatory cells. And we saw that not only CD8 T cells went up in the blood, but T regulatory cells went up in the blood. And it looked like the patients who responded were those that had some defect in their T regulatory cells where they didn't expand. And that sort of linked the response to IL-2 to the autoimmunity that we also saw associated with response. One of my first papers I wrote talked about thyroiditis and with a high-dose IL-2 therapy and its association with response. And so I find it amusing that that field has been rediscovered. But the way we thought to improve the therapeutic index for high-dose IL-2, after we couldn't do it by combining it with chemotherapy and combining it with interferons and combining it with other targeted therapies, was to see if we could selectively activate CD8 T cells. And so naively, we thought that maybe having non-alpha IL-2s would do that because the high affinity receptor tended to be on Tregs, and if we didn't bind to the high affinity receptor, maybe that would actually allow for CD8s to be activated without Tregs. The trouble with that assumption, and it was naive when we think about it, is there was no selectivity for doing that within the tumor microenvironments. And so you were going to activate CD8 T cells in the periphery and in the tumor. And if you wanted to do so in a way that was not toxic, it was going to be low-dose IL-2, which was not effective. And so after a lot of failed attempts that I think were, in retrospect, predictable, I think the field has moved towards trying to selectively activate tumor-specific T cells within the tumor microenvironment with cytokines. And so we're looking at masked cytokines. We're looking at IL-2 that's targeted to cells within the tumor microenvironment, either through targeting PD-1 or targeting hopefully CD8s, which may be more concentrated in the tumor microenvironment. Or there was a nice presentation by James Gully at SITC looking at a bispecific that brought IL-2 into the tumor microenvironment by targeting a specific V-beta chain on TCRs that was enriched in the tumor microenvironment. And I do think that those types of approaches, and a number of companies are now working on that without as much support as I think they should be receiving, will ultimately work and will be supportive of not only increasing the activity of checkpoint inhibitors, but also may help with TIL, with T-cell engagers, anything where we want to get more T-cells working in the tumor microenvironment. So I have not given up on those.
I wonder, Mike, the
great.
intralesional. Oh, sorry. Are we having my internet is going in and out a little bit. Sorry if I'm jumping on you, James.
No,
Mike,
carry
I wonder.
on, carry on.
Okay. Thanks. The intralesional IL-2 that we saw at ASCO, the Daramune, it was interestingly called a pivotal trial, but that was just the name of it. It wasn't necessarily its stature. Mm-hmm. I wonder what you think about that intralesional working on Tregs and CD8s in the tumor, or is that too sort of pedantic an approach to just shove the IL-2 inside a tumor?
Well, we used to do that. We gave IL-2 injections into tumors like 30 years ago, and they did work on that tumor, but I don't think you get the T cells to be active and go to distant sites with that approach. And so, I think that may be fine for some patients where intralesional therapy
we're having
might work, but not. I think the best approach ultimately, if you want to get to all tumors.
Yeah, great. Go on, James.
No, we're having a few technical glitches, but we'll keep going anyway. So this is a bit of an unscripted question, but it's something Sapna and I talk about at least a little, and it's about complete responses to therapy. So if I'm honest, much of the cytokine stuff was a little bit before my time, but I was sort of taught growing up by Martin Gore that if you're treating someone with cytokines, then you really need to have a complete response to therapy to have properly durable benefit, shall we say. So do you think that's right, is the first part of the question? And then the second bit is, do you think we should be thinking exactly the same thing with other immunotherapies, checkpoint inhibitors being the obvious example? Do we need to really be chasing CRs? That's what Sapna and I call it, this idea of chasing a CR up front to really get the durable benefit.
Well, yes and no. First of all, I don't think that a CR on a CT scan or a good PR on a CT scan might be a CR. And so I don't think the CT scan should be the final arbiter of whether you've eliminated the last tumor cell. We know that from the neoadjuvant treatments, but that is true when you give things systemically as well. And back in the day when we were calling things CRs, we weren't even using CT scans. We were using like chest x-rays, or Steve Rosenberg used to use tomograms or things like that. So as you get better and better at imaging, the ability to actually eliminate everything on a scan becomes less and less. So I think a CR is necessary. You want to get rid of the last tumor cells, but not a resist CR or a radiographic CR. We just need better ways of proving that, which is why we've tended to, when we wanted to stop therapy and there was still something there and still something there on the PET scan, we tended to biopsy or resect a lesion. And if it was no tumor there, then we assumed that all the disease was probably gone. And I think, in the future, we'll have alternatives to biopsying the tumor to show that the tumor is gone, hopefully with sensitive ctDNA or other approaches. But that is the goal, to get rid of the tumor, put the patient in remission, stop the treatment, and get them back to their pre-cancer life, albeit informed by their experience that they went through in facing their cancer. And we call those patients who have stopped therapy, their disease is still under control, not just survivors, but thrivers, because they're back contributing to society in a robust way.
I mean, I wonder if that just sort of begs the question, Mike. We all know your IL-2 paper, obviously melanoma and kidney cancer, with the plateaus of CRs and PRs. And really, if you get that at 3 years, that's what got us thinking into, response at 3 years can be quite durable, regardless if it's CR or PR. But I guess it begs the question, what were you using back then to call a CR?
Yeah, we were using CT scans that weren't as good as the scans we had.
Yeah. Okay.
And we didn't have things like central review either. It was just us going to the radiology suite, pulling out the scans, which were on films, and measuring them. Technical difficulties. People are frozen. I hope it's not from me.
No, we're. This is a real. Go on, James.
No, don't worry about the screen. Yeah, you don't need to worry about the screen freezing. It's an artifact. We just, as long as we can keep talking, we should. When I was training, we still very much, one of my jobs as a junior doctor was, at the back of the ward round carrying the envelope with the old-fashioned scans on, and then when asked to bring the scans up to the front and put them up. Fond memories of that. So listen, to maybe come a little bit more up to date, I'm sure people will want to hear about DreamSeq, which has been an incredibly important trial, I think, over the last several years in terms of how we treat metastatic melanoma. So it'd be great if you could say a few words about that, maybe the background and the results and some of the subgroups. I think you talked about this at SITSI. Just go on, very interesting.
Yeah, so clearly huge advances in the treatment of metastatic melanoma, particularly BRAF mutant melanoma, with combination BRAF MEK inhibitors, which tended to play the progression-free and overall survival curves, and the combination checkpoint inhibitors, which had less of an effect on the early part of the curve, but tended to raise the tail. So in 2015, just as both of these combinations were approaching approval, we launched the DreamSeq trial, which took patients with metastatic BRAF mutant melanoma, randomized them to either getting combination Nivo-Ipi up front or combination BRAF MEK, in this case DAB-TREM, and if they progressed and met the eligibility criteria, they crossed over to the alternative therapy. And one of the key things about DreamSeq is because we thought those curves might cross, we didn't think a hazard ratio was the appropriate endpoint. We thought we should look at a landmark overall survival. So we chose 2-year overall survival as the goal, as the primary endpoint. And we estimated, and this is one of the things I'm proudest of, we based our statistics on the fact that we thought the Nivo-Ipi would have 70% 2-year overall survival, and that the DAB-TRAM would have 50% overall survival. So we predicted a 20% difference in 2-year overall survival. So the study was a bear to do. We were on like Amendment 23. We were accruing about 1 patient a month. We would probably still be doing this study, except for the Data Safety Monitoring Committee was looking at the data, and they saw this statistically meaningful, clinically significant 20% difference in overall survival at 2 years. 72% versus 52% favoring the immunotherapy first arm. So that stopped the study. About 90% accrued, only 59% of the patients had passed the 2-year time point. And then we struggled to get that published because we hadn't completed the trial. So one of the things that we thought about was, why was immunotherapy better? And there are 4 major reasons, in my view, why immune therapy first was better. First, it was better in all the subgroups, even the subgroups of patients where we thought targeted therapy did best, those with low LDH, good performance status, less than 3 metastatic sites of disease. Immunotherapy was better. The duration of response was much longer with immunotherapy. 80% of the 88% of the responders to immunotherapy were still responding, and only half the patients who responded to targeted therapy were responding. Third, there were the relapses that we were seeing were more frequent in the CNS with targeted therapy than with immune therapy. So immune therapy was working on that subclinical brain metastasis, preventing those relapses, while targeted therapy didn't do as well as that, something that we verified subsequently in the Checkmate 204 study. And then finally, targeted therapy worked as well after immune therapy as it did in the front line, while immunotherapy didn't appear to work as well in patients who progressed on targeted therapy. And because of all that, it was stacked so that the immunotherapy first would be the better arm. So we wanted to see if we could identify, because the curves crossed and there were some people who died on the immunotherapy arm, there were more deaths on the immunotherapy arm in the first 10 months than on the targeted therapy arm. We wanted to identify who those were, and clinically those were patients with aggressive disease who never got targeted therapy, at least on protocol. But we wanted to look a little more closely at that. We did a modified forest plot where we looked at PFS for the initial treatments, 2-year PFS, and looked at the difference in 2-year PFS. And immunotherapy was better 2-year PFS than targeted therapy in every clinical category, which was surprising to me. And this is, in the cooperative group, this is not just a selected institution. Right. And for overall survival, although the difference was not quite as robust for many groups, there was a significant difference in overall survival for the immunotherapy first, and in no group was the dot for the difference of favoring even non-significantly targeted therapy first. I want to pause for a second, because another thing that surprised me is that the response rates were the same to immune therapy and targeted therapy. And that's really an artifact of when we chose to measure the responses. In the targeted therapy studies, responses were measured at 8 weeks and 16 weeks, because we wanted to have the CT scans for targeted therapy done, for immunotherapy done at 12 weeks and 24 weeks. That's when we measured the responses for targeted therapy. And so there were plenty of patients who were responding at 12 weeks, but by the time they got to 24 weeks, they had new disease, or the disease was growing, or they had brain mets, who never counted as a response, who would have counted as a response if we had measured their scans at 8 weeks and 16 weeks. So that's why you might see that being different than what was predicted. So we wanted to see whether we could identify, because we had tumor tissue on patients, we could identify, looking at RNA-seq on the tumor tissue, a subset of patients who might do better with targeted therapy. And we looked at a lot of different things, and immunotherapy did better in most of them. But one of the things that was curious is that if you had an angiogenesis high signature, you did poorly with both targeted therapy and immunotherapy with 25% 2-year progression-free survival. But when we looked at the patients with angiogenesis high at their overall survival at 2 years, it looked like the targeted therapy first was above the immunotherapy first. And we tried to figure out why. And so we looked at what happened with second-line targeted therapy versus immunotherapy. And the patients who got immunotherapy in the second line after progressing on targeted therapy tended to have, and these are the patients who actually got to the immune therapy. Most of those patients, I suspect, didn't get to immune therapy because they had aggressive disease. But the ones who got to immune therapy had a response rate of 70% compared to the 25% response rate that you have in the front line with immune therapy. And targeted therapy did not work well after immunotherapy in those patients who still had aggressive disease. And so that suggested that in that group of patients with really aggressive disease, that a short course of targeted therapy, similar to what was done in Succumbit with the sandwich arm, might be the best approach to allow the tumor to shrink, to allow the hypoxia to reduce, and to allow the immunotherapy to fully be able to work. And so we're now going to validate that with the second half of the tumor specimens, but I think it does create an approach to patients who are presenting. Keep in mind that the patients with really aggressive disease probably didn't go on this trial because they didn't meet the eligibility criteria. And those are patients we were probably giving targeted therapy to. And we weren't sure when to switch to immune therapy or how we could do it. But now Succumbit helps us know how to do that. And DreamSeq helps us understand why that's a good approach.
Yeah, I mean, Mike, that was an absolute master class in DreamSeq for for people who need to know the ins and outs of it. I will say, I think you were so careful when you designed the study. To a lot of people, it may have just seemed like a, well, what do you give first type of study? But just the fact that you knew you had a really strong hunch that these curves would cross. Statistically, you knew what to do there. And it's incredible. James and I have talked about it on here before, but there's other studies that have come out. If they had just understood rapid responses versus, takes a while to get a response and then durable, if they would have understood the crossing, they would have known not to power for a median overall survival and a hazard ratio. It's a landmark. So we saw it, this ASCO with one of the targeted immunos that, for some reason they had an OS as their primary endpoint, which really didn't make sense, particularly after DreamSeq. I think it also tells us, you've taught us so much about DreamSeq over the years in terms of the patient population that went on. We know ECOG2, patients, if we're putting on an ECOG2, we know they're really a 3. We know they're, slipping and we're getting them on study. But to your point, the sickest of the sick are probably getting the targeted therapy first. And as James has pointed out when we talked about DreamSeq, the DreamSeq probably actually underestimates the benefit just because of some artifacts that were built into the study, the washout period, the fact that you have to reach your immunotherapy in order to see what the benefit is, et cetera. But I think all this angiogenesis stuff is really relevant for kidney cancer as well, right? James, you seem to have smoothed out with the connection, so maybe I'll give it back to you if you want to ask a kidney cancer question or two.
Yeah, I mean, for those who didn't see a talk at SITC, it was obviously a title after my own heart. As someone who also treats kidney cancer and melanoma, there's a few of us, I guess, around the world. Hopefully more, actually, I would say, in the future, because I think there's quite striking similarities, actually, between the diseases and the way we treat them. And I was there at ASCO last year, actually, in the audience when there was a discussion which you started, which really is about, in kidney cancer, what do we do with first-line metastatic treatment? If we put to one side the issue of adjuvant therapy in kidney cancer for a moment, is it ipi-nivo or should it be VEGF targeted therapy plus a checkpoint inhibitor? And I have to say, and I think you know this already, I'm 100% with you on this particular question, but it would be great if you could just say a bit about that for the people that are listening, because I think it's very instructive.
Yeah, so this is one of my great frustrations, and I hope I'm making progress in this area. So, first of all, as everybody who treats melanoma knows, because the immune system can target multiple different antigens simultaneously and broaden and deepen over time, it can eliminate the last tumor cell and produce cures. And therefore, the hallmark of an effective immunotherapy is this tail on the progression-free survival, or overall survival, or duration of response, or most importantly, treatment-free survival curves. And that's second nature for people who treat melanoma, to look at the right-hand side of the curve, the tail, rather than focusing on the left-hand side of the curve. But GU oncologists who treat prostate cancer mostly don't understand that, and they're stuck looking at the left-hand side of the curve. And so I also have the advantage of studying angiogenesis inhibition translationally in patients with kidney cancer. And what we saw in our mouse models and reproduced in patients is looking at perfusion MRIs. When you give a VEGF receptor TKI to a patient with kidney cancer, you see in the tumor an infarction. Within 3 days, the blood vessels disappear within the tumor. And the reason why that happens is because kidney cancer has a VHL mutation, and therefore it is able to have VEGF around without causing hypoxia, and therefore it never needs to develop a sophisticated angiogenic drive. The only way you get that angiogenic drive is after you block VEGF, make the tumor acutely hypoxic, and then you cause upregulation of other factors which lead to the resistance to the VEGF receptor TKIs, what we called angiogenic escape. And to me, that's the worst time to try to fully activate the immune system, is in this hypoxic tumor microenvironment. And so we were involved in some of those early IO TKI trials. I led the first phase 1 trial of Pembro plus Exitinib, and we saw this beautiful response rate, 70+%. We saw a median PFS in this really favorable risk population of close to 2 years. And if that was great, and I was following these patients, and then I had a few patients where I had to stop the TKI for one reason or another. They were having a stroke, or they needed surgery or something like that, and their disease exploded. And so I'm thinking, where is the immune response in this response? Because in immune therapy, that would not happen. And so this looked like it was just accentuated VEGF targeted therapy. And so we looked at those curves, and those curves look like TKI curves. They don't look like immunotherapy curves. There's no tail on those curves. As more time goes by, they just get lower and lower, and those patients are still on treatment. They're on treatment for the rest of their lives. Putting them on a TKI, which is a great treatment, is a one-way dead-end street. You can't cure them anymore. And so we've then tried to focus on just making the immune therapy better. And so the first thing we did after the Nivo-Ipi trial, and which I think vastly underestimated the efficacy of Nivo-Ipi in kidney cancer, because people didn't know how to use it. And they didn't know how to continue using it after they had a toxicity. They didn't know when to switch to a targeted therapy in patients who weren't responding, which is what happened and why the favorable risk patients did so poor on that trial. But we did the Nivo-only trial, what we call the HCRN trial, where we biopsied a metastatic lesion before we gave patients nivolumab. And then if they progressed We biopsied again to prove there was cancer there, and not always was. And then we switched them to Nivo-Ipi. And we've learned a lot from this trial. We've learned that first, Nivo has a decent response rate. It works well in favorable risk patients, that the Nivo-Ipi failures on 214 were probably because those patients never got targeted therapy, as we've now shown. And that I think the whole IMDC categorization, which was developed for VEGF receptor TKIs, doesn't apply to immune therapy. We knew from our IL-2 days that those favorable risk patients responded probably the best to IL-2. And if this VEGF was actually synergizing with anti-PD-1, you would have seen those patients do the best, but their survival was no better than starting with sunitinib. And so we also learned about all the things associated with resistance to immune therapy, and things like PD-1 on Tregs, or exhausted CD8s that have LAG3 and TIM3 on them, or SLAM-F7 expression on subset of CD8s, or whether or not there's tertiary lymphoid structures in the tumor. And some of those gave us ideas for how we could improve frontline immune therapy. And we're now pursuing that in clinical trials through our clinical trials group. And hopefully we can raise the bar above Nivo-Ipi, cure more patients, and convince these physicians who think that they need to get the best initial response and prevent early progression, and that's what their patients want. Instead of curing them, we can convince them that they should give a pure immunotherapy first, and that's the best way to cure patients. And that should be not just for intermediate or poor or sarcomatoid patients, but for all patients unless they're in some sort of clinical crisis.
Yeah, well, that was a tour de force. And a wonderful summary of, I think, where we are today, and also the history of immunotherapy to treat cancer over the last several decades. So, Mike, I know your schedule's extremely busy, so I'd like to thank you for joining us today.
Can I close with one thing? Yeah, so we've talked about melanoma and kidney cancer, but I think this approach is relevant for a lot of cancers. And I just wish the people who are treating those other cancers with immunotherapy would consider giving the best immunotherapy first. If it's in the first-line metastatic setting, or as Sapna has shown in the neoadjuvant setting, we should be going for cures, not for improving median PFS. And I wish the FDA would value that more, because that's what patients want. It may not be what pharma wants, but that's what patients want. And as advocates for our patients, we should want that too.
Yeah.
So sorry for that speech.
No. What a great way to finish. So, listen, thank you so much. It's been wonderful to have you with us, and I hope the technical problems didn't cause too much trouble for you. So, thank you very much. Good to see you.
Thanks, Mike.
My pleasure. Take care, you guys.
Thank you.